We're at the top of the hour, so I think we'll get going. Good morning. Welcome to today's webinar, Meeting Patient Access Goals with Better Prior Authorization Management. My name is Phil Dolan. I'm Chief Growth Officer at Valer, a provider of automation technology that speeds and simplifies prior authorization management. Before we get underway, I'll share a few housekeeping notes. First, today's webinar is designed to help educate you on the approach to improving your prior authorization management. There is no product demo today. If you do have interest in Valer's solution, you can request follow-up in the survey that you'll receive at the end. Even if you're not looking for help with today's prior authorization management, we'd love your feedback on today's webinar. Survey respondents will be entered into a drawing for a $100 Amazon gift card, and we'll let you know who won in our follow-up email. We invite your questions throughout today's webinar, and we'll address as many as we can at the end. You'll find a Q&A button at the bottom of your screen, and I will read questions to our panelists at the end. You may also use that same button for chat with other thoughts for attendees and our panelists. Finally, we'll be recording today's webinar. We'll make today's recording and slides available, and we'll send both to you by next Wednesday, March 27th. I'd now like to introduce you to today's speakers. First, Dr. Steve Kim is a co-founder and the CEO at Valer, a provider of solutions that automate prior authorization and referral management. With more than 20 years of medical experience and a passion for studying value-based care outcomes, Steve's experience has been vital in navigating the evolving complexities of the healthcare industry and identifying the administrative roadblocks and bottlenecks delaying access to care. Before Steve's transition into entrepreneurship, he was an assistant professor of urology at the University of Southern California's Keck School of Medicine. While at Keck, Steve also served as the Director of Clinical Research Informatics for Children's Hospital Los Angeles, in addition to practicing pediatric urology. He earned his undergraduate degree at Yale University and was awarded his medical degree from Cornell University Medical College. Ryan Lawrence is the Assistant Director for Centralized Managed Care and Price Estimates, overseeing authorization submissions, insurance verification, and price estimate functions for OHSU Health System. Ryan joined OHSU in April 2018 as the manager of front-end revenue cycle operations. Her major focus over the last few years has been orchestrating an organizational prior authorization transformation and implementing price transparency standards to achieve her strategic objectives. Ryan has over 20 years of experience in both for-profit and nonprofit healthcare entities and is CRCR certified with HFMA. Steve, I'll ask you to take it from here.
Thanks, Phil. Good morning, everybody. I want to thank you for taking time out of your busy schedules to join us today. I wanted to give a special thank you to Ryan for her willingness to share some of her success story at OHSU with everybody on the call today. We want to provide some practical takeaways for you all to come away from this webinar with. The first is really just understanding what is the broader impact of prior authorizations on patient care and on your practices. The second will really to provide a framework to help you think through the approach to dealing with prior authorizations and where automation technology might be applicable. We'll touch just briefly on some of the different approaches to automation that you may want to consider as you think about the choices. And the most important part here today is really Ryan being able to share how OHSU has utilized technology to kind of speed and simplify prior authorization management for their patients. And hopefully we'll have a few minutes at the end to go ahead and discuss any questions from those on the webinar today. Next slide, Phil. So as Phil mentioned, I'm a pediatric urologist from Children's Hospital Los Angeles, and I co-founded Valer out of my own personal frustration and anger of the impact that prior authorizations were having on my patients and on my practice. There wasn't a day that went by that I didn't see the insidious effects of prior authorizations on how it delayed patient care and how it really handcuffed my ability to take care of my patients. Also, at the same time, I saw the endless hours that my team spent filling out fax forms, logging and typing into multiple different payer websites, or even just stuck on the phone for endless hours trying to get a prior authorization. So it's because of all these things that over a decade ago that I knew that I had to do something about prior authorizations, and that's been the journey of our development as a company called Valer and the technology that you'll hear a little bit more about. Next slide, Phil. So how painful are prior authorizations? This slide is busy. It's intended to scream just how angry us physicians are with the whole prior authorization process. This is some information from the American Medical Association. They did a physician survey of their thoughts on prior authorizations at the end of 2022. And I'll just cover a few of the things that really kind of resonated with me as a physician. First and foremost, a third of physicians felt that prior authorizations led to a serious adverse outcome. Unfortunately, I'm in this number of physicians. I have seared permanently in my memory just really horrific outcomes of some of my pediatric patients that I felt related to prior authorization delays. 94% of physicians report that prior auths delay care. We all kind of know that and feel that. 80% of physicians have reported that their patients have just gotten frustrated. They've given up and abandoned the care treatment that we had recommended for them. Other numbers here that stand out, on average, providers will generate about 45 prior authorizations per week. Certainly in my Medicaid practice, it kind of felt like 45 authorizations per day. And so this is some of the real quantification of the burden for practices that they face every day. Lastly, 88% of physicians would categorize the authorization process as being extremely or high or extremely high in terms of the level of burden that we all face. And so really a good summary of some of the pain points that we're all feeling about prior authorization workflows today. Next slide. So in terms of quantifying the time and cost, this is information for the most recent 2023 CAQH index report. First and foremost, I think one of the things it pointed out from year over year was an 11% increase in the amount of transactional volumes and administrative work. I think we're all living and feeling this as just the sheer volume of authorizations continues to increase, largely driven by an uptick in Medicare Advantage plans with the prior authorization requirements. Prior authorizations are also incredibly manual. Still 70% of prior authorizations today require manual intervention by staff to go ahead and process and complete. On average, it takes about 22 minutes for authorizations to be conducted by staff or providers at a cost of around $11 per transaction. So prior authorizations are still incredibly manual, they're incredibly time intensive, and obviously incredibly costly. Next slide. So now that we've kind of covered some of the numbers behind the pain and just how difficult it is to deal with prior authorizations, we wanted to provide a framework for you and your organization to think about how to approach tackling prior authorizations and applying automation. The first step is always to identify the key challenge areas that you want to focus on and prioritize within your organization as to where to start. And what you're seeing here is probably stuff that you've already have been trying at your institution or organization. A couple of different lenses to look at it. One is the cost implication. Where are your staffing needs growing rapidly? It's just really difficult to keep up with the need to hire more people to keep up with authorization volumes. Everybody has been telling us about challenges and issues with staffing shortages in patient access teams. It's just really difficult to recruit and even to retain patient service representatives. The other frame that many organizations will tackle and approach in terms of prioritization is what is the lost or missed revenue opportunities? We know that in certain areas that denials and write-offs can create substantial financial impacts for organizations. And so there may be a focus on areas that would have the biggest financial benefit in that regard. The delay in care, cancellations, and reschedules were something that I was always frustrated with. And so what is the impact overall on patient care, but also on financial ramifications for the organization? Lastly, pretty much everybody does this, but really focusing on narrowing where do you want to start, where are the kind of key areas or locations of prior authorizations, diagnostic imaging, surgery and procedures, infusion therapy, notice of admissions. These are all areas that we get asked all the time to help organizations with our automation technology. One suggestion or consideration is that you may want to talk or partner with your finance and rev cycle teams to maybe identify kind of high areas of ROI opportunity based on some of these factors that you all review that we've gone over here. Next slide. Once you've kind of determined several areas that you want to focus on, the next part is understanding the workflow considerations and steps where automation may be applicable. We've kind of broken it up into four major kind of components here that we find are useful to kind of think through when you're actually reviewing what type of automation technology you may want to consider. Auth determination, simply is an authorization required or not, is typically where most of the vendors out there are focused on. There is some relief on the way as there's been legislation passed that will hopefully force health plans to make this much more transparent and apparent over time as to what auths are required. Where we focus as a company is really around the next two buckets, which is auth submission and auth verification. In our experience, this has been the most manual, the most error prone, and the most friction points when it comes to authorizations that we really feel like we can provide some opportunities for automation and ROI that you'll hear a little bit about from Ryan in a few minutes here. Lastly, auth denials, what can be done upstream on the front end that can help avoid or mitigate authorization denials is another important consideration when you're thinking about authorization automation technology. Next slide. So the last and final step is actually 3 sub-steps. And this may be a mantra that you've all heard before, but it's something that we find incredibly useful when you're thinking through how to approach prior authorization transformation and automation, is really people, process, and then the technology. So first off, really people, what are your staffing needs currently? What is your staffing capacity? We work with many clients and prospective clients on how to quantify this around what are the authorization volumes that you're currently responsible for, factoring that by the average time per authorization. We can help to quantify what is the amount of work effort and also to help provide an ROI around what automation technology can do to help improve that, right? Other aspects around people, training and education, obviously, and accountability. We frequently find that most organizations don't have visibility or insight as to what people are doing. And having this accountability is a very important concept to really kind of think about as you look at automation technology. The middle pillar here is process. Workflows are incredibly important when it comes to understanding prior authorizations. This is where you're really going to want to engage your subject matter experts and the people that do the work day to day to really understand several key components that will factor into your success with automation technology. First and foremost, your EHR, your EMR platforms, what are the workflows around authorizations within them? A lot of what you will be able to do will be dictated by those constraints or kind of what data is available. So really get to know what is actually around and available for automation. Next is really diving into payer-specific workflows, really understanding what payers want in terms of which web portals to go to. Is it a fax form? What type of questions would be asked? Really kind of understanding what is the set and body of work that your teams are currently doing and what could be automated. And this really breaks down into various different service lines that you want to focus this on. Lastly, organizational structure. I know every organization is a little bit different. Are you centralized? Are you distributed and decentralized? Is there a desire and interest to move towards centralization, which we hear about at many health systems? Those are all considerations as you start understanding what does the process and handoff look like amongst your organization. Once you have a solid grasp and foundation of the processes is then when we recommend to really look at technology. What are the core capabilities of some of the different components that we talked about? And what are you looking for in an authorization automation vendor to kind of help deliver ROI? Is it determination? Is it submission, verification, or inquiry? And also importantly, kind of really understanding what part of your workflow will get covered engaging in automation with a particular vendor. And this is really payers, what sort of payers will be covered, especially down to which lines of business and service lines. Next slide. Last slide, really kind of talking a little bit at a very high level about prior authorization automation technology. As we all know, not all technology is created equal when it comes to prior authorization automation. Many of you may be very familiar or have even tried or are currently using robotic process automations or RPA bots. I think the general experience that we've heard of is a very kind of middling response in their ability to drive real ROI when it comes to prior authorizations. RPA bots have difficulties getting onto payer websites in the first place. They're very fragile when it comes to all the payer changes. And so that's what we typically hear about in terms of that approach. Our approach is a little bit different at Valer. We call it user-centric workflow automation, where we're actually automating the workflow that your team members are doing. And you'll hear a little bit more about this from Ryan in just a few minutes here. Other considerations is really, are you looking for a best-in-class vendor when it comes to prior authorizations, that really has expertise and understands the complexities and nuances? Are you really thinking about it more of an overarching RCM vendor that does eligibility, claim statusing, a whole host of other options? Another consideration in terms of what type of ROI you're looking for. And then really understanding payer coverage and how do automation technology vendors handle the payer changes. And so with that, hopefully this was a very high-level overview of some of the strategies that we have found useful at organizations. And really, without much further ado, I turn it over to the star of the show, Ryan, to share her journey at OHSU.
Awesome. Thank you, Dr. Kim. I paid him to say that I'm the star of the show, but that's fine. As you said, my name is Ryan, and I am the Assistant Director for Managed Care and Price Estimates at OHSU. I'm just going to walk through kind of our journey at OHSU as we partnered with Valer to try to automate our authorization process. So let's go ahead and get started. This is my bragging slide. This just talks about all the wonderful things about OHSU and how big we are and who we service, our community here in Oregon. So you'll get this slide so you can read all about how wonderful they are. Can we move right along? All right. So this slide is here to show you an accurate representation of what the authorization process is here with all the different colored medley of string. Currently, if you're doing authorizations or you get to sit with any of your managed care staff or folks doing your authorizations, you know that this is pretty spot on with what it looks like with all the different payers, websites, faxes, so on. And this lovely light bulb that looks, more of what we would like it to be is kind of where we've been headed for the last couple of years or 3 years as we've partnered with Valer. Next slide. This is an actual picture of me. This is how I feel or felt as I started this process. I have been in the industry for quite some time, and I have heard a lot of vendors talk about automated authorization. I think it's different to every vendor. There are a lot of different options out there, and I definitely said these things. I definitely have said that it's too hard, too expensive, can't be done. But all of that to say, like, I definitely think we've found a way to improve on this very manual process. Next slide, please. In order to do that, our team had to think outside the box. So I like to use this quote from Henry Ford as he was building the Model T, asking folks what would be helpful. And, most people just said a faster horse. And a lot of times here in our industry, I hear we need more people. We need to just throw more people at it. And that's just not the answer. We need to work smarter and not harder. So next slide, please. These are the three key takeaways that I'm hoping you will get from our presentation today. Just really understanding that we can simplify prior authorizations, or at least make it more simplified than it currently is. I'm hoping you'll see what steps we took and be able to take those steps on your own. And then also just drilling home that I know that this is a lot of time investment, and I know that everybody out there has limited resources. I completely understand staffing shortages, but it really is worth it in the long run. It's very important overall. Oh, we're going back in time. All right, so I'm going to start here by just talking about where things have been and what we saw when we started. I joined OHSU back in 2018, and one of the first things that we started to do was really dive into the prior authorization process and looking at our current EMR and how we were able to create a workflow. We at OHSU, I know it's somewhat of a debate on whether or not to get authorization prior to scheduling or after scheduling. We at OHSU schedule patients first, and then we attempt to get authorization at the same time. And we just feel that that is less of a wait for patients. So with that being said, we have a ton of work queues. When I started, we had all different work queues. They had all different insurances falling in. We were trying to make sense of what work needed to be done. Are we doing benefit checks? What are we doing in all of these? So we did a lot of work scoping our work queues to ensure that we had work that truly needed authorizations falling to those work queues. So after we had kind of reviewed our process, scoped our work queues, ensured that we were as efficient as we possibly could be, we started to realize like, hey, there are a lot of redundancies. And it just felt like, we really could leverage some automation to do these things that our staff are just constantly doing. A lot of data entry, taking information that's in your EMR and putting into another system for a payer to review. Because we're doing a lot of data entry there, there are errors. You type in an E, or you type in an extra number on an ID number, and you're gonna get some issues as you're sending things through. So a lot of errors that way, authorization numbers, not being correct, and then having to reprocess claims. The other area that we started to realize we really didn't have a good hold on was understanding, just where we were with our authorizations. Exactly what is our volume? What is the report? Do we have any reporting? We didn't really have great reporting out of our EMR to tell us, where are we with authorizations? How long is it taking us? Really, how many staff do we need for this, right? And then on top of all of that, as I'm sure you're aware of, staff morale and turnover was just suffering incredibly. Staff see these work queues. There's a ton in there every day. They're frustrated. They're trying to work through all of these. You have the providers calling and they're upset because their patient has to reschedule. It doesn't feel good. It definitely doesn't feel good. So we needed to really look at how do we improve this for our staff so that they want to do this job. They're passionate about it, but it's so challenging. So what can we do? Next slide, please. So we started to look at what is success for us? What are the key factors that are going to make us successful? How are we going to get there? So, we knew we wanted to look into a partner to help us with our automation. So we started out by ensuring that we had a good baseline measurement of where we were. We needed to understand what are we currently looking like? What do we have happening? How far out are we? How many people are we throwing at this every day? So we needed to understand that. We needed to ensure that we had the right stakeholders at the table. If anybody has questions about that, I'm happy to answer those because I originally came to the table without all of the stakeholders. One really important thing is to ensure that you are engaging your IT team. And then always your subject matter experts. It is so important to have that frontline staff available and working with you on what that process is and what that tool should be. We definitely leveraged our subject matter experts in building this tool. The other thing to think about is what is your training going to look like? Often you come up with these great ideas, but it's hard to roll out. We definitely wanted something that was going to be intuitive and user-friendly, something that we felt our team was going to be able to pick up and use regularly without too much frustration in the beginning getting started. And then ongoing coaching. So we wanted to make sure that we also had a partner that would continue to work with us as things changed, as we know in healthcare, that's the only constant is change. So as things change, as things come up, are we able or can we empower our staff to have those conversations with our partner and say, hey, this isn't working as we expected it to. Can we make some changes? Or, hey, this just happened. You know, it would be helpful. Can we maybe, can we look at doing something different? So that's really important. I tell the story often. I did work with a vendor one time where I went back and said, hey, this isn't really working the way that I thought it was going to work. Can we talk about maybe making some modifications? And I was truly told that the product was working as designed. And so that was just a really frustrating comment. And from then it has been like, how do I find a vendor that I can partner with and I can give feedback to? Next slide, please. So these are what we identified as our requirements, things that we wanted to make sure we focused on. So one, obviously, automating our process. We had scoped and become as efficient as we could. How can we automate some of these manual pieces? How do we save money? How do we ensure that we're saving on costs for resources? We know that, again, staff is hard to come by. We want to make sure that we're using them to the top of their pay scale. We want to make sure that they're doing the things that they should be, working in more of an exception environment where, like, hey, we need to get on the phone and have a call, not I need to submit this so it automatically authorizes. And then ultimately our goal of patient and provider satisfaction. How do we ensure that these patients get to their appointment every single time and get the care that they need without the burden of a financial situation? And how do we make sure that we're having those conversations really early in the game? Like, hey, you know, we need to make sure that you understand what your insurance is authorizing, what they'll allow and what they won't. So it's very important to try to get that as early as you can. So, you know, these are key pieces that we wanted to ensure that we were getting from a tool, and you will get these slides, so you can certainly read through all of the details. But, you know, just overall, I definitely wanted a tool that interacted with our EMR. It didn't make sense to me that we would, you know, kind of do the same thing where we're taking information from our system to put it into another portal to then go out to other portals. So it was really important that we had something that spoke to our EMR. And then as far as, you know, getting our staff to use it, you definitely have to have something that your staff are engaged in. They feel like it is just part of the tool that they're currently using. You know, it's easy to work out of the EMR that they're currently in. So we wanted something that was going to be easy for our folks to use, and we wanted to gain that efficiency there. As I spoke earlier about, you know, errors, we all see them. I like to tell providers when they're sometimes frustrated, I'm like, well, you know, we have humans are doing this. So there are those moments. So anytime we can reduce or mitigate that, you know, I'm all in. So how can we try to decrease these errors? We did find a lot of duplicate work, a lot of places where, you know, we're logging into a portal and we're checking for the authorization. We're going back, we're putting that information into a system. So it's just a lot of duplicate work. And then, as I mentioned, just ensuring that this tool was built around us and our process and how we do things. So one other piece that I want to just throw out there that is kind of an important thing to remember, as I was talking to different vendors, you know, one of the key things was like, okay, well, what payers do you work with? Because I know where I am here in the Northwest, we have some pretty specific payers to our area. You know, that are a good portion of our patient population. And so when I asked, do you have connections with these payers, you know, when I got the list, it was about 30% of our payers. So really, I wanted to identify a team that would work with all of the payers that we specifically work with. So it was really important to call that out. Next slide, please. This slide just kind of gives you an idea of how the tool works for us. So at OHSU, we're an Epic shop. We utilize Epic as our EMR. We are able to trigger an account to flow out of our EMR. It goes over to Valer with all of the data, patient name, information, which insurance they have. And then Valer takes that, ingests that information, and then they prepare to send that off to whichever place it needs to go, whether it be a payer portal, that we can do it by fax, carrier pigeon, whatever it might be. But this kind of speaks to all of that. I have called this magic before. I've literally said this is like wicked magic. It just goes through, and then Valer does all their magic pieces, and it gets over to the payer, and the payer's happy. We're happy. But this is just kind of an overview of what that looks like for you. Next slide, please. So I know everyone's excited about, well, what is your outcome? What did you see for ROI? So this is a slide that actually is information from last summer. And I'm really horrible. I know I need to go back through and do my numbers and volumes again. It's just been very busy. But specifically speaking, I will say, we pulled this data looking at like our diagnostics team. We have a lot of diagnostic imaging that comes through our facility. And so we really wanted to look at this and say, we know 90% of this is going to require an authorization. So this is the biggest bang for our buck. Let's start here. Let's see what we can do. And we have seen some pretty significant improvements. We did increase our volumes by 11% as of last summer, and we did not add staff to take care of that volume. We went from being, when I first started at OHSU, we were at about 3 or 4 days out. We had improved with some of our scoping. We got to about 5 days out. I will say now on a regular basis, we are at about an average of 13 days out, which means 13 days prior to the patient's visit, we have submitted and obtained an authorization. So it's obviously important to try to get as far as you can. Our goal is to be 21 days out. Because we feel like that really gives us that time to have those conversations with the patient. But you can see this is a dramatic improvement for our team. We really reduced the amount of time that it's taking for them to submit authorization, to check the pending, to push it all back into Epic and ensure that we have everything in the appropriate fields. So this kind of gives you just a nice little outline of where we have seen some significant improvement. Next slide, please. So this slide speaks to the amount of time that it generally takes to submit an authorization. And again, if any of you have done this, you know that it can be incredibly frustrating, especially if you're going through and you submit things and something goes wrong, and then you have to start it all again. So this can be a very tedious process. It takes anywhere from, we see things from 2 to 7 minutes for a quick submit, and then it comes back and tells you right away that there's an authorization, and then you have to take that information and put it all back into your system. So it really can take up to 24 minutes. Some authorizations might take even more depending on the questions that you get, all of the fun clinical questions that the team has to answer. So we really wanted to look at how do we take away all of those, those minutes that are spent entering the information, waiting for the response, getting it back into the system. And how do we ensure that our team is really just there to do the pieces where you need more clinical documentation, you need to have a conversation about it, you need to look further into something. So rather than just kind of taking those ones that we know are going to get authorized, how do we spend our time on the more challenging ones? So this helped us to kind of look at what our ROI was. And one key thing that we don't call out here that I think is important is the amount of time that your staff is spending just checking on a pending authorization. Meaning they are going out to a website, they are putting in all their credentials, they're pulling that up, they're checking they're putting the patient's information in just to see the auth is still pending and they're still waiting. And depending on how soon that visit is, it can be, multiple times a day. So we have it set up so that Valer actually checks for us. I think we currently have it 4 times a day, where they are checking for a pending authorization. And if there is an approval there, it will bring that information back into our system automatically, updates the fields appropriately, and it falls out of our work queue. So our team doesn't have to touch that. So that's just a little bit about our savings. So let's move to the next slide. I love data. I use the slogan data before drama all the time with my team. It's very easy for us to say things like, this is always happening, or this is never happening. But if I can't go to my CFO and my VP to say, this is the data to support what we're feeling, then they're just going to kind of giggle. So it's really important for us to have good reporting to be able to paint the picture and tell the story of where we're seeing bottlenecks or issues. So I will say what was great about Valer is I have been able to say, okay, well, how long is it taking us to submit to each payer? And they've been able to bring that information back and say, this is how long it is on average. This is what each payer does. This is how long it's taking you to submit. This is how long it's taking them to answer you. And so I can take that data. I've been able to take that data back to our teams and say, hey, do we have anything in our contracts that say that they shouldn't be taking more than 15 days to get back to us? And another area, I just want to tell a fun story real quick. Just recently, I said, okay, for all of our authorizations, our diagnostic authorizations that we're sending to this payer, can you tell me how often they're automatically authorizing these? And so I got a report that tells me 99% of the time they're authorizing the CPT, 100% of the time they're doing this, 95% of the time they're doing this, they're never authorizing this. So it's important to have that data to then go to my contracting department and say, hey, can we have a conversation with this payer? Because it's administrative burden on us and it's administrative burden on them. They're authorizing this every single time. They're authorizing this 99% of the time. Is it really that important for us to submit this each time? And so we've started that conversation with one of our payers and to look at not having to submit those authorizations to them anymore for those CPTs. So I think it's very exciting to be able to bring that data and say, hey, you're feeling this too, right? Yeah. And maybe we can not do this anymore. So really important. All right, let's go ahead and go to the next slide, please. So this is the roadmap that we're on. So I'm sure all of you are kind of in the same place, right? You're looking to get a touchless authorization. That is where I think we are extremely close. I think we have a lot of opportunity, especially if you have things that are hard-coded in your system. The idea is to, create an author or create a request and have it automatically go over. We currently have what we call bulk submission. And what that is that our team is able to go through for certain payers and just trigger them all to go over to Valer. And once they do that, Valer knows they're going to take all of that information that was sent over for that payer. And at the end of the day, they're just going to submit it for us. So our team isn't going to do anything else in the system. They're just going to go ahead. They're going to submit it for us. And for certain payers, we have said, these are the questions they're going to ask every time. This is how we want you to answer it. And they'll submit all of them without us touching them. And then if they're approved, they automatically send them back over with an approval and they drop out of our work queue. If they pend, our team gets a notification in the morning with a report that says, hey, all of these need additional work. So it's been really cool watching us kind of get to almost a touchless place. So now that we've got some data, we've been able to say, hey, like this percent of the time, we're never having to touch these again for this payer. We're at a point where we're ready to look at how do we just have the system trigger once the order is put in? How do we have it just automatically go over without our team even triggering it out of Epic? It just automatically goes. So that's where we are with our touchless authorizations. So when I say we're so close, we are so close. So I think we're going to be there pretty soon. I'm hopeful, fingers and toes crossed, that it'll happen for summertime. automated notification of admission. So I know that I am probably on a soapbox right now that you all also are feeling. I think that's the notification of admission is the most useless thing that there is. We're literally contacting a payer to tell them your patient's here with us. Not that you won't know when we send you clinicals or anything like that, but we literally have to call or fax or go to a portal to notify a payer, hey, this is your patient's information, they're here. So what we are in the process of doing right now is setting it up so that our information will go right out of Epic, and Valer will take that information, ingest it, and send it over to whichever payer it is to notify them that their patient is here. We've been building this, and I'm super excited to say that we are now at a place where I believe next week we will be putting it into some real submissions. We've been working out of our test environment and seeing how we are able to send things back and forth through our connection, through our Fund 278 connection and our FHIR application. But now we're at a point where we've got everything built out. And so we're hopeful that next week, actually, we will have our end user start using it and giving us feedback on how that's working, just triggering all of them to just go out of our system. And then ultimately, we'd like to get to a place where we're utilizing or leveraging our 278N so that it automatically goes without our user touching those at all. So that's where we are with that. And so then I can free up that FTE to work on all the other things we have, as you know, with managed care and price transparency. And then also the other thing that we've been working on is building out our policy or our guides within the tool. So right now our team has some pretty robust guides and some cool tools on our shared drive or a SharePoint that we constantly update with new information, like what does this payer require? What's the biosimilar for this infusion? Oh, by the way, this payer only wants, Udenica, so you can't give them this one. So those are important things for us to know, as well as like, hey, there's a site of care restriction on this, or this payer, requires that they have X, Y, and Z before they can do this treatment or get this scan. So instead of having that out in a separate area, we're building that within the tool. So that way, when someone is submitting to that payer, it'll come up in the tool with a nice little like, hey, look at me. FYI, you need to make sure that you've got this taken care of, or that the provider knows that they require this biosimilar or this treatment first. So just kind of putting that information at their fingertips. We've already gotten to a place where the tool allows us to submit multiple submissions at one time. So it literally pulls up multiple tabs for us. And we can kind of watch what's happening. Like we can see, okay, this one is pending. This is pending. This one just turned green. That means it's good to go, and we'll see it drop off. This one turned yellow. I need to go there and answer questions. So we've already gotten to a place where I think, we're really utilizing the tool to help us submit more efficiently. Also kind of making sure that we're able to do more than one thing at a time, especially if you're on hold with a payer and you're waiting for them to pick up the phone, you want to be able to do more than one thing. So we've already gotten that with this tool. So really our next goal is how do we take it to the next level? How do we get it so that we can remove our FTE from doing these manual tasks, these, redundant tasks, these things that really, should be automated. And how do we educate them as they're working through these things? So those are our goals. That's where we're working right now. Like I said, since we've already, I think, gotten the tool to a place where, I think we've built out a lot of efficiency with what we have. Next slide, please. All right, so just to go over those key takeaways again, hopefully I was able to answer for you that simplifying your authorizations it is a possibility. Hopefully you kind of see the steps that we took, things that we thought were important, things that we wanted to make sure that we shared with the world, things that we learned as we went through this process, and the fact that it is it is worth the investment. I mean, you know, one of the things I think that's really cool is when you have somebody that's onboarding. We just, you know, we definitely have some newer staff and we're onboarding them. One of the things that's pretty cool is like, instead of having them go out to 15 portals and pull up, you know, 100 different faxes and get to know all those pieces, we are able to say, hey, you know, you do it one way for all of these. You do it one way. There is one central location, one platform that you're on. It always looks this way. It always looks the same. It's going to pull that data in for you. Like, those are things that I think are important, key takeaways from this. So hopefully you got that. And if you didn't, I'm happy to answer more questions. All right. I've come to the end of my speaking. I will stop now and answer any fun questions y'all may have, or actually you can direct them to Dr. Kim.
What wonderful job, Ryan and Steve. We've got a whole bunch of really great questions. I don't know in the remaining 15 minutes that we've got that we'll have the opportunity to answer all of them. But what I will do is, for those of you who have provided your name with your question, which is most of you, I will commit to getting you answers after the webinar if we don't have time to address your question today. So Ryan, this first question's for you. It's from Sarah. She says, Ryan, do you have situations where certain payer groups, not the whole payer, are out of network? How has this process helped you in identifying the out-of-network plans? I wonder if Ryan is frozen.
I don't know if Ryan's frozen.
Maybe Ryan's frozen.
Certainly, we'll give Ryan a chance to jump back on. Oh, I think we might have lost Ryan.
You know what I'll do is I'll come back to that question, Steve, and I'll ask this next one of you. Ryan, I think you froze up. Did you hear the whole question?
I heard nothing. Sorry, my system froze.
Okay, let me repeat the question really quick.
I told you I wasn't answering anything. And then I was like, bye.
Ryan, do you have situations where certain payer groups, not the whole payer, are out of network? How has this process helped you in identifying the out-of-network plans?
So yes, we definitely, you know, we're on the struggle bus too with the in and out of network payers. So I will say at OHSU, we have that kind of, that's knowledge that we have within our system. We don't rely on Valer to tell us whether or not something is in or out of network. We haven't utilized them for that piece. We have a central location in our share drive that tells us, you know, what contracts we have in and out of net, or what we're contracted with. And then we have our guides that are scoped to tell us, you know, whether or not something is in or out of network, but we haven't necessarily leveraged the tool to tell us that.
I will maybe just a little bit where some of our other clients, where we do have the ability to flag things based on some of the information that Ryan talked about in the SharePoint, to flag things that are sites of care, you know, or out of network facilities. And so that is a capability that we're seeing a lot more requests for. And so we work with our clients and our partners to kind of develop those business rules on a basis that they'd like implemented. So that's certainly a possibility.
Ryan, this next one's for you from Pamela. How do you handle if the procedure changes or additional procedures are done during surgery that are different than those that were originally authorized? Great question.
Oh, Pamela, that's such a pain point. Yeah, so actually we utilize a work queue. So if something, we have authorized a CPT or something different than what actually gets coded into the system, we have it dropped to a work queue. So that way we can resubmit for or amend our authorization request. And in those cases, we can resend through Valer. We do have the opportunity to retrigger and send through Valer. But that's kind of how we're using that right now. I'd like to get to a place where we know right away. I know there are some facilities that have some cool ideas, but we know we're using a work queue to drive that information back to us if it's coded differently than what we got authorization for.
Great, that's helpful. This next one's for you as well, Ryan.
Oh, good.
When you figure 22 or 24 minutes on average for the manual process, I think she's referring to that slide you showed earlier. Does that cover all service lines, for example, surgical cases, high-end imaging, cardiac cases, rehab, et cetera, or just certain ones?
Great question. So that's actually going based on the teams that we have up and running on Valer. So at OHSU, we are a hybrid right now. We're partially centralized, partially decentralized. There are some pockets. We have about 70% centralized currently, and we're continuing to centralize more services each year, hence the growth that we've seen. What we do, what I will say is that is mostly made up of our ambulatory visits. And that's because we built the tool to interface with our referral. And currently, since we're working on notification of admission, we are now building the tool to interface with our auth cert, and that will allow us to do our surgical pieces. So everything that we have for our surgical care, we're doing out of our auth cert. And so we want to build the tool so that it can speak to or fill in those fields that are required. Right now, we just have it for our referral. So it's mostly our ambulatory work. We don't really have our inpatient surgical pieces being done through referral.
Thanks,
I hope that helps, and I can answer more about that if you have further questions.
Yeah, that's from Joan. So Joan, if you have further questions, let Ryan or me know. We'll get back to you. Another great question from Sarah. Have you been able to automate a split prior authorization? Split meaning, for her purposes, would be a surgical prior authorization that includes a specialty pharmacy drug?
Yeah, so we can trigger separately to two different payers. You can trigger to medical and you can trigger to a separate payer. I will say that we don't do much that we haven't really done much of that. We started building out our infusion process recently, as I said, kind of going through that site of care. We know, hey, this drug request for Blue Cross goes to Magellan, and so we've started to build that out. The other thing is within Epic, we don't have it set up currently to have specific multiple authorizations. So I know that is something that we're going to be looking at with our upgrade. We don't have Beacon. I don't know if you have Epic, but we're currently in the process of implementing the Beacon referral module. And so we're hopeful that will kind of help us to split things out a little bit better and be able to submit through Valer a lot more clean. Right now, we're utilizing our staff to manually add those CPTs, where the Beacon referral should allow us to take that information straight from the order and be able to send it over to Valer. But long, I guess, answer. That was a long answer to say that, yes, you can split. You can trigger twice for different payers.
We do have other clients and other EMRs that are doing the split for infusion therapy. Split authorizations are also kind of covering the secondary insurances as well. That's something that factors into it.
Steve, this next question's for you. Which EMRs does Valer interface with besides Epic?
Certainly, Epic is one of our primary integrations. We have clients that are on Cerner, on Athena Health, on NextGen, the Veradigm Allscripts platform, GE Centricity. So there's quite a few different EMR platforms that we've done integrations with. That has been a strong suit of our company, is just really extensive integration capabilities. And so that list is growing. We're in conversations with many other EMR vendors as well to add on the inventory side. So that's a little bit of a list, but we're certainly happy to give you a more comprehensive list and follow up.
Steve, this next question is also for you. We are a Rule community hospital using Cerner. Is this tool beneficial for the Cerner system and a hospital serving a community of 30,000 and growing rapidly?
Yeah, certainly we do have several Cerner clients. May not necessarily be in a rural community per se, but in locations in Oregon actually, where they do have a broad footprint with community providers and referrals. And so certainly it sounds like the organization's growing. We'd be happy to kind of have that discussion about how we might be able to help both on the authorization front. And I know we're not talking about referrals here, but that also comes up a lot for community hospitals and access hospitals. So happy to discuss that further in follow-up.
Great. Thanks, Steve. All right, Ryan, this is, I'm sure, a very common question. This is for you. How do you integrate automations in a staff that is fearful of their jobs being replaced by automation?
Yeah, that's a good one. No, I think just like I was saying, it's so important to get them involved at the front, to make sure that you have people who, the more that they have a say in it, the more comfortable they are, and the more they recognize that, okay, this is something necessary. But on top of that, we didn't reduce or remove any of our staff. We reallocated that staff. So for us, it hasn't been your job is going away. It's, hey, your job is changing. You're no longer going to need to be, submitting authorization as much as you are now. I'm going to need you to create patient estimates and have those conversations, those financial conversations with our patients ahead of time. Try to, to pre-collect that payment, have those conversations and make sure that patients understand what their benefit does cover and what it doesn't, and what that financial implication is for them, maybe getting them connected with our financial advocates. So really kind of trying to ensure that they understand that their job or the need for them isn't going away. It's that we now need you to focus a little bit differently. So it's still the financial experience, right? Still the patient financial experience that we're involved in, but a little bit different in trying to educate patients further upstream rather than, hey, I just got your authorization yesterday and now you have a $3,000 deductible I'm telling you about. So.
Thanks, Ryan. I think we've got time for maybe a couple more questions. Maybe Steve, I'll pose this one to you. This is from Cynthia. Are the automated tools for acute services or ambulatory? Is the system compatible with DOS systems? Are you able to identify surgery and/or imaging CPT changes to secure what is truly being done? There's a few questions within a question there, so I'll come back and remind you if necessary.
Think that's got a lot of different threads in it. So I'll kind of at least at a high level answer the initial question. We're primarily kind of on the ambulatory and outpatient side of things. However, for inpatient surgeries that are elective, we certainly are doing that type of activity. I think one area that we're not focused on yet as a company is the inpatient kind of case management process with interqual and MCG and some of the other things there. But that's certainly an area that we're looking to explore down the road. And really across, just I know that at OHSU they haven't kind of gone across all the different areas, but just generally speaking, we're working with all the different service lines out there. Surgical procedures, outpatient ambulatory GI procedures, we do PTOT rehab, we do a high clip of DMEs as well. So that's kind of our primary focus right now. Is the system compatible with DOS systems? I might need some more clarification. Maybe we can follow up with you, Cynthia. We do kind of extensive integrations with a large variety of different systems. I've seen a couple of green screen DOS type systems, but we'll have that discussion maybe and follow up with you with our IT team to kind of better understand the type of systems you're on. The next question there, are you able to identify surgery and or imaging CPT changes? Might need to kind of follow up with you to kind of get more of your exact question. Certainly, if the question is if you've ordered certain sets of CPT codes for surgeries or imaging and the payer is not approving all the CPT codes, that's something, in fact, that we do. We do flag that for our clients to call out if there's been a change in the approval of what codes have been approved by the insurance company, and that's something that we reflect based on individual client preferences. Many of them will have an approved but requires attention. And that's also the case for if the site of care is being changed. We are seeing this more and more where the approval process, they're switching it to a different preferred facility. And so we've got ways in our platform to go ahead and flag that. But certainly we'll follow up with you, Cynthia, to kind of make sure that we have the right questions being answered there.
Great. Well, I'm showing 1 minute to the top of the hour, so we don't want to make anyone late for your next meeting or lunch or whatever the case may be. So we'll answer the rest of the remaining questions that were posed, but that we didn't have a chance to answer live today with you separately, unless you've posed the question anonymously. There were just a couple of those. So with that, that concludes today's webinar. We want to thank you for attending. As a reminder, you'll receive an anonymous 5-question survey that will help us improve future webinars. Remember that we will draw one lucky winner among survey respondents for a $100 Amazon gift card. If you'd like to be entered in our drawing or have someone from Valer follow up with you, you'll have the opportunity in the survey to tell us. Thanks to all of you for attending today, and have a great rest of the day. Thanks, Ryan. Thanks, Steve.
Ryan, really appreciate it.
Yeah, thanks for the invite.
Bye.
Bye.